Pardon?
The registration center link.
Yeah, it's on that.
Hi everyone, I'm glad everyone made it out today. It's not a regular CHEPA seminar series time. It's a day earlier and also an hour and a half earlier than usual, I think, so, or an hour earlier than usual. And things changed at the last minute, so thank you all for coming out at the changed time and different date. But it's a great opportunity for us to get some people that I know personally through the door. Josh is one of them, as well as his colleague Dr. Adrienne Chan, here from Dignitas, representing Dignitas International. Dr. Chen's also an assistant professor at University of Toronto and appointed in the infectious disease unit as well as the School of Public Health. Josh is a knowledge translation officer, but he's making the transition, I just heard, to live in Malawi full-time as of February with Dignitas as the knowledge translation officer there. So I've known Josh for about 2 years. We first met in Addis at a knowledge translation conference, and the work that they're doing with Malawi is great. And so they're here today on actually quite short notice, which 2 to 3 weeks or 4 weeks. So again, thank you so much for coming, and they're going to be presenting on the prevention of HIV from child to mother, or sorry, from mother to child in Malawi. So without further ado, I'd like to hand it over to Josh and Adrienne, and I'll let them go. And I think 45 minutes and then 15 minutes for questions.
Great.
Okay?
Yeah, that sounds
okay,
good.
Great.
Great. Well, thanks, Kaylin. And yeah, Kaylin and I have been working together for the last couple of years. So Kaylin and John and their team has been really instrumental in helping Malawi. We won't talk about this too much today, but helping Malawi build a knowledge translation platform to more closely link the research outcomes that happen in Malawi, make sure that they're translated in a way that policymakers in the country can utilize them for evidence-based policy. So we were happy to come today. So yeah, Adrienne and I would like to share a little bit of a case study on the transition over the last 10 years or so of Malawi's mother-to-child, or prevention of mother-to-child transmission policy. So we really want to frame the talk today as a policy or knowledge translation cycle, and show you what the policy was, what the results were, and then as that policy has changed, and what the evidence was, and where we go from there. So in any sector, and we find this especially in health, and this is something I think, actually, before I go further, can I get a sense of who's in the room? Put your hand up if you're a graduate student. Okay, and an undergrad? Great, don't look shy, we don't discriminate. Great, and in the health, all of you are in the health or policy field? Yeah, that's good. Okay, great, so that just gives us a sense to where to pitch. So I was saying, in any sector, and we especially see it in health, there's a large gap between what we know and what we do. In health, obviously that has real consequences for people's lives, and in a low-resource setting like Malawi, it has even greater consequence. So just to give you an overview of the HIV epidemic in Malawi, there's just under 1 million people living with HIV currently. We've had some success over the last several years in bringing down the prevalence. A large proportion of, or over half, of people living with HIV are women. Does anyone have a sense of why that is? So 2 reasons, and Adrienne, jump in if you think of others or have others. One, biologically, during heterosexual sex, women are more likely to acquire HIV. And then also gender inequalities, especially in places like Malawi, when you're negotiating using a condom or not using a condom, it's difficult for women to really push for that. Any pieces you want to add to that, Adrienne?
Yeah, one of the interesting things that we've seen also, like prevalence is, the prevalence is also directly linked to survival on treatment. Mm-hmm. So just thinking about it in terms of the opposite lens, it's interesting. We found that since we've rolled out ART that women are much more likely to access treatment earlier than men are for a variety of reasons, right. Either through antenatal care, also because they're much more likely linked into the health system through maternal child health programs. So a lot of the men that we see on programs actually, they have worse mortality rates. They're accessing it later. So I wonder if we're also seeing
So it's
that imbalance as well.
So it's both acquisition and staying on treatment.
Yeah,
staying alive.
it's an interesting piece. Also, how men aren't accessing care.
Right.
Yeah.
So over 100,000 pediatric cases and 80,000 infants born each year to mothers that are HIV positive. So it's obviously something that we'll get into more, the prevention of mother-to-child transmission. Just as a quick note, if an HIV infant is left untreated, half will die by the age of 2. So it's a serious thing that we need to work with. So this is just to give you a sense. This previous slide was talking a little bit about the disease burden in Malawi. Obviously, HIV is a huge burden on the healthcare system. You also have tuberculosis, you have malaria, you have diarrheal diseases. There's a large burden on a weak health system. And this gives you a sense of the patient load, and also a sense of, down here, there's 50,000 people in this catchment area at a small health center in the southeast zone of Malawi, staffed by one medical assistant, which is somewhat equivalent to a nurse practitioner, and 2 nurses. So it's a weak health system, a large disease burden, and part of the reason it's a weak health system is because of the lack of human resources. The big takeaway from this slide is that in the absence of any intervention, 1 in 3 children will acquire HIV from an HIV positive mother. So we really need to intervene in this population, and you can see here where along the cascade that the transmission is occurring. So this slide looks to get at the cascade of PMTCT and how we want to intervene at every step along the way to minimize this down here, obviously the infected infants. So we want to prevent new infections, we want to avoid unintended pregnancies, and then if an HIV positive mother does become pregnant, we want to make sure that we intervene as early on in the pregnancy as possible to prevent mother-to-child transmission. So Adrienne's going to talk a little bit about the policy and the outcomes that we've seen over the last several years. But just to kind of give us some context, in 2004, or 2003, let's say, there was no publicly available antiretroviral therapy, and no women were getting on treatment. And you think about that, that's, we all remember where we were 2001, September, that's not that long ago. And we've scaled up a huge amount in Malawi and throughout sub-Saharan Africa, and really seen HIV positive pregnant women get on treatment earlier and earlier. We're going to talk about the effectiveness of that treatment in a second, but the scale up that governments in Malawi, Lesotho, other countries have done over the last 10 years has been really remarkable in very difficult situations. So as Kaylin mentioned, both Adrienne and I work for Dignitas International. We're a medical and research organization headquartered out of Toronto, but primarily working in Malawi. We now have a small Aboriginal health program that's just begun in Northern Ontario. I'm trying to take some of what we've learned and some of the methods and tools that we've created over the last 10 years and see if there's room for some engagement in Aboriginal communities in Northern Ontario. But for the vast majority of our work, and Adrienne and I in particular, are focused on Malawi. So we started working there 10 years ago, right at the beginning of antiretroviral therapy rollout. I think Adrienne was there not long after that as the HIV clinic coordinator. Maybe you can say a minute or two about that. And really started and was integral in starting up our primary clinic, which is at Zamba Central Hospital. And then over the last 10 years, or over the last maybe 6 or 7 years, I should say, we've really expanded out through a mentorship and supportive supervision program. We put we've tested 1.2 million people, and this is obviously us in the Ministry of Health, us supporting the ministry. And we've supported the ministry in putting over 200,000 people on treatment. And Adrienne and others, I guess me, also have been pushing out what we consider, hopefully, some high-impact research. We'll talk a little bit more about that. So So the prevention of mother-to-child transmission programming in Malawi, so as I mentioned, in 2004 was when the first antiretroviral therapy treatment in the public sector began in Malawi. Before that, in 2002, you can see almost no one was getting tested. And ANC stands for Antenatal Care Clinic. So this is pregnant women, newly pregnant women coming into the clinic. You would think now, now we look back at that statistic and it's remarkable to us that it was such a low percentage. No one was testing. And obviously that's the beginning of the cascade. If we don't know you're positive, then you're not going to get on treatment. So the first piece was really to scale up the HIV testing and counseling access to women that were coming in. So a rapid test was introduced in 2003, and in 2005 it became opt-out, and that's when we really saw some gains. Dignitas began working in this area in 2005 and has really expanded our reach and our engagement in the prevention of mother-to-child transmission over the last almost 10 years. So Adrienne's going to talk also a little bit about what we do now in the prevention of mother-to-child transmission programming. I'll talk a little bit, some of these we still do. This is one of our staff, and I should say in the Toronto office we're about 15, and the technical team is smaller than that. There's maybe 4 or 5 full-time equivalents. With people like Adrienne being part-time and having clinical duties here. The vast majority of our team is Malawian, in Malawi, in Zamba. We have over 100 staff now. This is Chrissy Gondwe, who is our, now works on our Teen Club program, back then worked also on our PMTCT program. Chrissy's a good friend and really has been, you look at some of the team that we have there really doing amazing work every day. Chrissy is one of them. So we do a lot, or we did a lot in the prevention of mother-to-child transmission programming. We're going to talk a little bit about expert patient mothers. That's something we still do and are now testing that as we begin to roll up and roll out our PMTCT portfolio of work. And at the beginning, we were also making sure, as I mentioned before, that HIV testing and counseling was happening at the Antenatal Care Clinic as the beginning of the cascade. Okay, yeah, it's just this.
So for me, it's interesting looking back at this, right? Because it was World AIDS Day yesterday, so it's been about a decade since we started our program in Malawi. And I think, what you're not going to get from me is a sales pitch about our organization. I think what you're going to really see is a frank. The next piece of the lecture is really kind of about what over the last 10 years we were successful at, but also what we were abysmal failures at. And I think the important piece in this is that over time, because we've had 10 years of building a relationship with the Ministry of Health, and because I think they see that there's a lot of critical self-analysis about what we're doing, I think because of that they've been willing to listen to us when we say this isn't working. And I think one of the big pieces that came out to me through PMTCT, and I feel very personally responsible for as the medical coordinator who was in charge of the program, is in fact how much of a failure it really was when it first started, and how we really needed to bring many people together in order to try to get the kind of changes that we wanted to see, and how in many ways it's an unfinished story that still requires a lot of work and a lot of that research to policy connect that I think you guys are interested in the work that you do. So one of the key things is that there are lots of clinical trials that happen. I'm an infectious diseases physician, so obviously I'm
Keep going.
Okay.
I have a quick question.
Yeah, sure. So obviously I'm very interested in clinical research, but the one thing I wanted you to take from this slide is that there was a lot of evidence out there about what worked and what could work. But that didn't necessarily translate into real life and what was going on the ground, and I think that was something that I really felt as the medical coordinator working in the program, that even though there were many studies kind of up until I got there in around 2007 that showed that you could reduce the rates of transmission, of vertical transmission, from greater than 40% to less than 5%. My sense is that what we were implementing at the time, Dignitas as a program, the Malawi Ministry of Health as a program based on the WHO guidelines, wasn't actually doing what we needed it to do. And so one of the things, so we looked at the evidence, the Thai PHP-T2 study, the SAINT study, showing that you could basically reduce transmission rates from 40% to, with single-dose nevirapine, which is a single drug taken at pregnancy, at delivery, and then given to the baby, you could reduce it to around 10%. But this is also taking into consideration the fact that, in a lot of these studies, women were given replacement feeding formula instead of breastfeeding, not taking into consideration the context of what goes on in a setting where you don't have safe access to water, right? You can't afford formula or the implements that are needed in order to have this is a viable option in order to keep your child healthy and also well nourished. And so one of the things that we implemented along with all that work, and we're talking about a program that not for us but internationally millions of dollars went into, was going out there in the field. You just had a real sense that even though we were giving women single dose nevirapine or this complicated combination prophylaxis regimen which the WHO had recommended, that it was complex to implement, even though it worked in the study setting, in a real life setting where you had, one nurse, dealing with a catchment area of 100,000 people. That they weren't able to see it implemented all the way through to the point where you actually saw that you could prevent vertical transmission. So we knew that there are a lot of clinical trials going on out there looking at various forms of treatment for mothers and babies throughout the antenatal cycle and into the breastfeeding period, but we wanted to see what's actually happening on the ground in our program. We can say numbers like we get a certain number of women onto antenatal treatment, but are we actually preventing infection from happening? So we did a very simple study where we basically went to all of the maternity registers in our district, to all the 24 rural health centers that we had decentralized antiretroviral treatment to, and we went back and we tried to track down as many of these mothers as possible to ask them, did you take the regimen that was given to you, and then also to test test their children to see whether or not the children were HIV infected or not, and then get them back into care. And what was really humbling about the study, I kind of expected that this would happen, but to actually see it, I think I think it was very impactful for me to kind of realize, I'd been implementing this program for maybe around a year and a half by that point, and essentially what we found was that this program that we put a lot of investment into, we found that only 18% of the HIV-infected mothers followed all of the recommendations that were recommended in order to prevent transmission. That even though there was recommendations that women stop breastfeeding at 6 months at that point to decrease the amount of transmission, 50% of HIV-infected mothers were still breastfeeding at 2 years. And during that postnatal period where there's breastfeeding, transmission can still occur. And a lot of those times, women weren't actually on treatment at that time. And what was also quite disappointing to me, but in some ways not surprising, was that if we looked at HIV-free survival of infants, it was just as bad as if we did nothing. So this showed that in an operational setting in Malawi, that implementing the guidelines that were recommended by evidence and that the WHO recommended at that time were just as bad as doing nothing. So why do a study like that when you know that there's all these other things going on in terms of producing information? And I think one of the important pieces is that at that point in time, we were coming to a tipping point. Okay? I knew that the WHO guidelines in 2010 were coming up. We were having meetings at the national level with the technical working group on antiretroviral treatment and PMTCT, and there was a lot of controversy over, do we continue with this old way of doing things, this combination prophylaxis, which in a study setting can reduce the rates of transmission to 2%, or do we need to move to something else? Because we're missing. We're missing a lot of women aren't getting on treatment because it's so complicated. They have to get their CD4 tested to see whether or not they're immunologically weak or immunologically strong. There's this complicated regimen that they have to use, and then it's not clear whether or not these women get treated throughout the postnatal period where they should be breastfeeding. And so there's a lot of discussions going on, and I think we felt at the time that even though this was a small operational study done in our setting in Zambia, the one thing I learned from working at the national level in Malawi is that if there's evidence coming in from South Africa or Zambia or Tanzania, which are countries close by, they still won't change things if they don't see that there's local evidence happening. And anybody who works in these kind of settings and works at a national level knows that the assumption that a regional context and evidence generated from a regional context is enough to generate change locally for the policymakers who are actually making the decision making is sometimes erroneous.
What is it that clicks people's minds to actually change? Often it's actual evidence coming from the ground, even if it's small evidence. And I think that little piece of information that we had showing that, yes, you guys are implementing these things that the WHO is telling you to do, but look at what's happening. Our HIV-free survival in rural Malawi is just as bad as if we're doing nothing. It was a real push for them to say, we really need to think about how we're going to adopt these WHO 2010 recommendations based on this other evidence coming in. What can we do to try to change things so that the program moving forward isn't as bad as it was? And it was interesting to me because even in the new guidelines that the Malawi Ministry of Health ended up adopting, they actually cited the article that we published on the evidence showing that things had done poorly. So it took a lot of time. Advocacy at the national level, like me telling them, I see patients, I don't think the program is working, that only works so much, because who am I? I'm a Canadian physician who's been in the country for a year and a half. A lot of the people who've been working on this program have been working on it since day one. I think you also see in some of these policy meetings technical experts coming in from outside. They do a lot of talking, but people will only listen a certain amount unless you kind of have built those relationships. So I think a little piece of it was the evidence, a little piece of it was the talking and the relationships in order to get things changed. So the big discussion in this context, kind of in late 2009 and early 2010, was where do we move forward from this? We want to move away from giving single-dose nevirapine. We want to move away from giving combination prophylaxis. What are the two ways we can go about this? So the two options presented by the WHO at the time, and this is another interesting lesson, because the Malawi Ministry of Health ended up going with option B. Option A, the evidence for option A was actually generated in a clinical trial that was conducted primarily in Malawi, a large clinical study that was conducted by the University of North Carolina at one of their sites in Lilongwe. And it was interesting to see, one of the things that Nina, who was the principal investigator, said is, like, I spent all this time and money doing this huge clinical trial and they're not actually listening to the results. So it was interesting for me to see kind of the process of what the Malawian policymakers went through in terms of them choosing option B over option A, even though the clinical trial evidence for option A actually came out of Malawi. The clinical trial evidence for option B came out from other sites in Botswana and Kenya and Ivory Coast. So what they thought was that it was important that that there be the big shift in the 2010 guidelines for the WHO is, as opposed to just kind of focusing on treatment in and around labor and delivery, which is thought to be the highest transmission period. They wanted to then extend treatment throughout the breastfeeding period because they basically saw that in our context, replacement feeding was not really an option. So the two options that they were considered were either to give the infant antiretroviral treatment until they stop breastfeeding, or to give the mother antiretroviral treatment until they stop breastfeeding. So really, it was at this policy tipping point in terms of where to go. So this is some of the evidence. There actually, at that time, there was no evidence showing a head-to-head trial between option A and option B. There's now evidence that's come out recently that does show that. But the transmission rates were about equivalent to both. There were a lot of people pushing for option A because it looked, on the surface and early costing to be a little bit cheaper than option B. So there were some people kind of pushing for option A at that point. But the real interest in doing B was that it was one of the reasons why I think the previous way of doing PMTCT wasn't implemented well was because it's incredibly complicated, right? Like, you'd have to identify a woman in antenatal, counsel her around taking a pill, and then counsel her around her giving her child a pill, and then maybe the woman would have to take a different type of pill for a week, and then the child would have to take a different kind of syrup it was a very complicated way of doing things. And I think that because we had been so good at scaling up antiretroviral treatment in the country, like hugely good, at that time we'd gone from 3,000 people on treatment to over 100,000 people on treatment over the course of 5 years nationally, the whole concept is B seemed a lot easier, which was basically you see a woman in antenatal, you test her, she's HIV infected, you offer her antiretroviral treatment that she'll then be on through the entire breastfeeding period. So one of the interesting pieces that kind of came up in the discussions was, in Malawi, the average fertility rate for a woman is 5.6 pregnancies for a woman during their reproductive years. So it's very different than in North America, where what we were doing for years was to give women antiretroviral therapy in and around their pregnancy, and then we would stop it if they were healthy, and then only start them later on if they became unhealthy and they progressed to the definitions for what we were putting people on for treatment at the time. So if you're going to start and stop and start and stop and start and stop, it might make more sense to basically take a test and treat strategy, use that point where they get tested as access of care, get them onto treatment, and then basically put them on treatment for life. And that was something that in the policy level, it was interesting in the discussions, listening to kind of Malawians and some of the technical advisors start thinking, does it really make sense to start and stop? Maybe we should do something else and not just listen to what the WHO is suggesting. We favor B, but maybe we should even go onwards. And instead of just stopping treatment at breastfeeding, continue treatment to account for the fact that many of these women will go on towards multiple pregnancies. So basically that's what they did. So as a whole, the HIV Technical Working Group basically recommended to the Ministry of Health to adopt this new strategy called Option B+. And what was interesting is that this wasn't pushed by the outside, it wasn't pushed by the donors. It's been taken on by donors, in particular PEPFAR, to be pushed out very broadly, but this really came from within the country. This was a Malawian idea that was based on the context, based on us understanding that a simplified public health approach was really needed to approach this problem, and to basically recommend for the first time a treatment as prevention program being implemented at a population level. So it was kind of exciting to be a part of this discussion and to see kind of the various pieces of information that came in: clinical trial evidence, WHO guidelines, internal evidence, technical advisor and local policymakers kind of discussing, and then them coming out with this policy to basically start all pregnant women on treatment. And so the idea is that it would be simplified delivery, and that the other thing is that for the first time it was prioritizing maternal mortality and morbidity as well. So it was something that I think that everybody thought would be a really good way to move forward, and that's basically what we decided to move forward. I'm going to skip past some of this. So these are the new guidelines that came out in early 2011. They basically recosted their Global Fund grant to supply for this, and then they started to do all the training and to start rolling out the treatments in Q3 of 2011, and been rolling out that ever since. So what's been interesting is, at this point you stop and you think, okay, so there's great things about this idea, but there's also many other things that haven't been addressed, and there could be many problems, and I think all of us are really aware of that. I don't know what you guys think, just listening to what I've said. Does Option B+ and doing Option B+, does it address some of the issues that go around uptake of treatment and transmission? What could you guys see could be potential problems with this strategy? If I explained it clearly enough. Because it's interesting, because the WHO moved forward with recommending this in the 2013 guidelines as the way to move forward, and PEPFAR has been dumping a huge amount of money to roll this out to many other countries in Southern Africa, and we don't have a lot of evidence around B+. So, yeah, go ahead.
This seems pretty obvious, but I don't know if the change from Option B to Option B+ requires a substantial more amount of funding.
Yeah, it does. Yeah, it does. It does. So that's a big piece. Is it sustainable? What does it mean? Is it something that programs can afford? Yeah. What other issues?
There may be, issues with adherence for a lifelong treatment.
Yeah, absolutely. So I think that's one of the biggest concerns, right? Is that you're taking a group, you're basically taking a group that otherwise was seeking care, just going to seek antenatal care, right? The reason why they're coming to the health center is they're happy, they've just found out they're pregnant, they're gonna try to link in with the health system, and then they're suddenly told, you're HIV positive, you need to go on treatment for life. They don't feel sick. They need to tell their partner who's at home, and we've already talked that there might be some issues around gender power issues and risks of stigma related to disclosure, risks of gender-based violence related to the disclosure. You're telling them that they have to go on treatment for life. Are they going to do that? Are they going to take that medication and just throw it away and never come back to the health system? If you get them on treatment, are they just going to stay on treatment during their pregnancy? Are they going to continue it all the way through breastfeeding? Are they going to stop once they stop breastfeeding? There's so many things we don't know about that, and I think that was one interesting piece that those are questions that we didn't have answered when we move forward with things. Any other concerns? Yeah, go ahead.
I think, like, similar to that point, just being able to reach women who are in very rural areas.
Yeah.
Like not having, or like not being able to afford the transport necessarily.
Yeah. Yeah, so that's one of the things that's a really good point. I do think in Malawi it's relatively addressed in the sense that, so what they did was they decided to roll out this program. When we started working in Malawi, we were really doing slow decentralization. So Dignitas had done decentralization in our district. The 2 MSF, Doctors Without Borders programs, had done decentralization in their district. But in the rest of the country, decentralization was way behind. One of the interesting health systems things that happened with this program is because they knew they needed to get antiretroviral treatment into all of the antenatal care facilities, basically within the span of 6 months, they decentralized ART to every health post, rural health post in the country, which is great from an access perspective, but then what problems could you see happening if you're doing a rapid decentralization like that for a relatively weak health system? It's just a lot of extra work and a lot of resource burden on human resources that are already constrained, right? So if you're suddenly going to take an antenatal care nurse who's just used to dealing with pregnancy and then telling her that she now has to manage 12% of the population on lifelong antiretroviral treatment, that's a lot of extra workload. So even though it's great that you're decentralizing treatment, you're not necessarily bringing in the resources that it needs to do it effectively. So how is it that we deal with some of the human resources for health issues? In particular, will a facility-based nurse, they might prioritize things like getting women on treatment, but they may not prioritize things like chasing them down if they get lost to follow-up, or providing them with counseling and psychosocial support that they need to go through a program like this, right? Those are the things that I think kind of tend to get deprioritized and might not be supported from the public health system. So it's interesting that based on relatively low quality evidence, WHO decided to move forward with this in 2013, and it's being rolled out now in basically almost everywhere in Southern Africa, right? So they've gone from like doing not enough to kind of going crazy with something. And so I think the important piece is that, there are many different issues that we need to think about, things like cost and cost effectiveness you mentioned. Given that this is a health economics group, obviously you guys will be thinking about that. What are the impacts on the health system? What are the biological impacts on adherence and resistance? And also, are there issues with giving these drugs on such a large scale in terms of how it might affect pediatric outcomes? So we have some information from our setting, but not on the huge scale. Like I can count on my hand the number of pregnant women. Like I know all the babies. Like I remember everyone I've taken care of here who have had vertical transmission issues. In Malawi, we're talking about like tens of thousands of women. So it's on a much different scale, and it would be important to watch things like population level impacts of what some of these drugs could have. So the stakes are high. On the one hand, you could have elimination of pediatric HIV and also improve the life expectancy of HIV-infected women. On the other hand, you could have widespread defaulting, spread of resistance, and increase the risk of failure of the first-line regimen because you're starting people who aren't ready to be on treatment onto treatment. You also don't know what's going to happen with some of these drugs I mentioned. So these are some of the implementation challenges that remain that we all discussed. And so I think the way in terms of moving forward is, we want to take the lessons that we learned from the previous round, and instead of studying it late, as we're implementing, we want to study how we're rolling it out, and along with the government. And the government's really taken a real interest in this, right? They secured funding from the WHO and from CETA, actually, to assess their rollout of Option B Plus in a very systematic way, to look at some of the issues around what are the best models of care to roll out treatment. Are there better support models in terms of how we do the human resources for health piece, task shifting, for example, to try to support the rollout of this in country? And is it effective? So some of the early data that's come up about this program, so this is actually the Ministry of Health data is published in the CDC morbidity and mortality weekly report basically showed, so up until Q3 2011, when we started option B plus, very few women were getting on full antiretroviral treatment, and we've greatly scaled that up in terms of the number of new initiations since that time, and those numbers have continued to be high. But one of the interesting issues, so this is, Lyson Tintani is a monitoring and evaluation fellow at the national level. Malawi is so small that everybody knows each other. That's just to give you a sense. Lyson actually used to work for us at Dignitas as one of our research coordinators. So he's working at the national level, and he basically looked at all the data from a bunch of national sites that recorded their data on electronic medical records to see what was going on, and found that there was large variability in loss to follow-up at all the sites. Some sites had very little, like 5% of their women would be lost to follow-up. There were some sites where like 45% of their women were lost to follow-up. So we've been interested in looking at some of what those factors might be, and there certainly seems to be some facility-specific issues that are related to why some sites have higher rates of loss to follow-up than others. Lyson's group also found that a lot of where the loss to follow-up happens, it's much more likely to happen at urban versus rural sites, kind of what you got to. When women access sites at rural care, right, they're much less likely to default because it's much closer to home. The healthcare providers are much more likely to know them and be able to hunt them down if they're lost to treatment. Whereas I think in urban centers you get lost in the crowd and you get a lot of people coming in as tertiary referral that aren't able to get back there for care. There's also, interestingly, higher rates of loss to follow-up in publicly run sites versus the mission sites, where they sometimes have a little bit more resources and have built in some excellent home-based care programs to try to support people at home. Larger sites with higher volumes also seem to have higher loss to follow-up. And what was really interesting is that there seems to be a high risk of loss to follow-up after the first ART initiation visit. And this is a similar finding that's being replicated in our data, and also in the University of North Carolina and Lighthouse data, which is a big center in the capital city, where it seems like we're losing a lot of women early on. So I think what's happening is they get started on treatment on that first day, and they get the counseling on that day, but they're totally not ready, and then they just go home, throw out their drugs, and then they don't come back. So we're seeing a lot of that happening, and then, so as a consequence, we need to think, how can we support that and stop that from happening? This is a study that we recently published looking at various models of care. Just the take-home point from this is whether or not the women get the care at the antenatal care site versus referred to the ART site seems to have an impact on whether or not they're kept into treatment. Also, whether or not they're started on ART on the same day, and whether or not they're given a chance to think about it also seems to have an impact on their rates of loss to follow-up. So these are just kind of some of the bits of information. So I'm going to skip past here. Kind of, maybe you can talk about some of the other studies that we're doing to look into where option B plus is moving forward. Here.
So just to go back maybe just for a second. So Dignitas has been supporting the Ministry of Health in scaling up option B plus, but then we've also been one of several research organizations that are also questioning how best can we optimize. So it's a really aggressive policy that has the implications to really, you always hear about this AIDS-free generation. It has the ability to do that, but only if it's optimized well. And as Adrienne mentioned, there's a lot of unanswered questions with this policy. How to implement it and how to utilize it effectively to prevent these transmissions now is what Dignitas is really trying to study, and many others are. So Adrienne, I want to just go back just for a second to this study, because it's an interesting one. Just to say, the Ministry of Health came out with a policy that was going to be aggressively rolled out, but it lacked specific guidance on how to do this at the various levels of healthcare facilities. So at a tertiary level, it's going to look a lot different than at a rural outpost. And what we tried to do here was say, it's a natural experiment. This policy is being rolled out in all of these different health facilities. And a lot of these health facilities are implementing the policy in various ways. We could categorize them into these 4 ways. So some are doing it in ANC, some are doing it elsewhere, some are referring, some are keeping them in ANC. The details are less important. I mean, they're important here, obviously, but for us, what we wanted to do was, this natural experiment is happening. Let's group them and try to come up with a recommendation to say what implementation method could work best at various health facilities. So I think this paper is a really important one to say that there's a policy rolled out at a national level, how it trickles down to the health facility level can vary, and then we can try to get some data on what's been working so we can guide other health facilities in trying to optimize this care. So as you can imagine, with such an aggressive policy being rolled out, and Malawi was the first country to do this, that there is now a huge interest in studying the effectiveness and efficacy of this program. So I'm going to run through a couple of the studies, but just as a high level, there's a lot of research that's happening right now. Dignitas is part of some of it. To try to find out how can we optimize this aggressive policy, and how can we make sure that it's getting the best benefit for the most amount of people. So the NEMAP study is a large prospective cohort that's following over 3,000 mother-infant pairs across the country. We're really looking at outcomes here. Is this policy having the intended outcomes for individual patients? Do you want to talk about this one, Adrienne?
This is interesting. So basically, one of the things that has happened is that the Ministry of Health has developed very good standardized monitoring and evaluation tools to look at the program, and they've managed to get them all into electronic database, but just don't have the time or capacity to do the analysis. So they partnered up with these kind of big data people in HIV work. They're part of this IDEA cohort. And these people from the University of Bern, they have funding from both the NIH and the Gates Foundation to essentially just look at the Ministry of Health's data for them, and to try to support looking at patient-level data for operational research. So that's what Lyson is working on, and that's where he's gotten some of his information from. So the NEMAP study is actually looking more at clinical effectiveness. So it's going to look at whether or not it actually works in terms of reducing HIV vertical transmission and increasing HIV-free survival. Whereas the IDEA study, the Bern people are looking basically at programmatic outcomes. So at least at the large sites where they have electronic medical records. You'll get more information about what's happening at the secondary and tertiary level in this study. With NEMAP, it's going to be a little bit more at the primary health facility level. So it gives you different pieces of information.
Okay, so this is, the PURE study was the study that Adrienne mentioned briefly before, that the World Health Organization and now DFAT-D are funding, and Dignitas is a partner in this study, along with, as you can see, many others. The idea here is that we want to support women. So Adrienne mentioned before, you go to the clinic, you've just found out you're pregnant, you want to enter a health facility to start to try to have a successful pregnancy. And that same day the first time you go to the antenatal care clinic, they say, oh, you're going to have an HIV test. You kind of not thinking anything of it, you come back, you're positive. And that same day you're being put on treatment. And what we're seeing is a lot of women then go home and start to process all of this, and they start talking with husbands, and it gets complicated. And we're finding that that's a lot. Just imagine that you're trying to take in here. Imagine that in a rural, poverty-stricken place. It's a lot to take in, and we're finding that we need to support women, as Adrienne also mentioned, that have never shown symptoms of HIV. Many that we need to support them in trying to keep them on treatment now for life. So how best to do that? We don't have good evidence for it. So we're trying to generate that evidence now. So as part of the PURE study, we have 3 arms. One is routine care, as they would get now. The second and third are both with our peer mothers. So these are women, some contexts would call them expert clients or expert patients. Some are facility-based in Arm 2, or they're all facility-based in Arm 2, and in Arm 3, they're community-based. The facility-based would provide support groups, they'd phone call, they'd follow up with these women to try to keep them on treatment, make sure that their psychosocial needs are met. And then the same type of support, but in the community, is happening in the third arm. And we're going to test what works in trying to make sure that women start on treatment and keep on treatment for life. We've done some formative, qualitative, and economic work that really has now, I'm going to get to the results of this, which have now really informed the trial period. So in this PURE study, we're looking at maternal outcomes, we're looking at infant outcomes, and importantly, we're looking at male partner outcomes. Because we need, and we know through some other evidence, that male involvement is key to this whole PMTCT cascade. The more that we can get men involved, the more success we're going to have, preventing transmission and also keeping women on treatment for life. So as I mentioned, these are randomly selected throughout. So Dignitas works throughout the Southeast Health Zone, headquartered in Zamba. I'm kind of in this general area. And there's other partners that are working in other areas of Malawi. Okay, so I won't go through all of these, but these are some of the results, 2 slides of formative results that we've written up in reports but haven't published yet. So there's concerns, as Adrienne mentioned, and as I insinuated also, about immediate start on ART. In these bullets underneath each sub-bullet are saying what the PURE study is hoping that we can address. So these concerns about immediate ART startup, we're looking for these mentor and expert mothers to do this rapid education and then continue that psychosocial support throughout the pregnancy. There's still stigma, there's confidentiality and privacy, there's male partner involvement is a key, and we've shown that through other research, that the more that we can get the males involved, the better outcomes for the women and their kids. You mentioned earlier the cost of transport. So we're also, we could explore alternative routes to ART pickup. As Adrienne mentioned, we have done, the Ministry of Health, I say we as the ministry, the Ministry of Health with supports like Dignitas and other non-governmental organizations has done a great job of decentralizing the care for PMTCT. But there's still women that are having to travel long distances. So we do need to look at, and continue to look at, innovative ways to tackle the cost of transport issue. Adrienne also touched on this default or tracing. So in the standard of care group right now, there's not that built-in tracing. So what tracing means is sometimes physically or electronic means over the phone, going and trying to follow up people, and if they're lost to follow up, bringing them back in and trying to get them back in on treatment. Because we want these women starting on day 1, but then there's regular visits, obviously throughout their pregnancy and then after their pregnancy. HSA stands for Health Surveillance Assistant. So this is a formal cadre within the government of Malawi. You'll hear them often in other contexts or other countries called community healthcare workers.